Hello, everybody. I'll get you to grab a seat, please. I wanted to welcome you to our Occupational Environmental Health Seminar Series. This will be the first of a three-part series by candidates who are being interviewed for a new assistant professor position in environmental health in our school at this university. And I'll introduce our first of three candidates shortly. I have one piece of business related to our program, our Masters of Science in Occupational Environmental Health program, which is to announce the winners, the top two presenters for our practicum placement presentations that happened a week ago. So my pleasure to announce the two winners who will then be invited to present at the local annual meeting for the American Industrial Hygiene Association, and also to get a nice little UBC gift certificate. But our two winners were Dee Wu. Oh, Dee. No gift certificate for her, yeah. And the second presenter, top presenter, was Paige Glant. You can hand that down to her. Yeah, thank you very much. So my pleasure now. I have the honor of introducing for you Dr. Ajay Pillarisetti. So Dr. Pillarisetti is currently a postdoctoral scholar in household energy, climate, and the health research group, and a lecturer in environmental health sciences at the University of California, Berkeley. He currently co-leads research efforts in India and in Mongolia and develops tools to quantify, first, exposure to air pollution, two, household characteristics and energy use, and three, time activity patterns. He additionally creates software tools to facilitate the analysis of household air pollution related data sets and to model the health impacts of exposure reducing interventions using global burden of disease methods. He's broadly interested in the application of lower cost monitoring technologies to environmental health problems, including air pollution, heat stress, noise exposure, and especially in contexts where objective measurements are lacking. So we've invited him here to present today a little bit about himself, a little bit about his research projects so that you get a chance to know him. There is an evaluation form for this presentation, and I encourage you, this is your opportunity to provide input on the candidate in terms of their research as well as their presentation skills. The link is on the board. The marker wasn't the strongest, but you'll see the link there via our website. I encourage you to complete that form, providing feedback on this seminar at the conclusion. But I'll ask you to join me, please, in welcoming Dr. Pillarisetti.
Hi there. Thanks so much to the department for hosting me, and to all of you for showing up, and to those of you online for signing on to watch this. So I'm going to talk a bit about my work on household energy and health in India and beyond, and some measurements and modeling we've done around those contexts. So just a brief outline, do some background about me and about the research, and then talk about ongoing research now, some future work, and then teaching and collaboration. Let me see if I can unknot this. There we go. All right, so I did an undergraduate degree in biology and English at Emory College in Atlanta, Georgia, and there I was really involved in a program called Science and Society, which tried to translate science happening on campus and at partner institutions to the public. And part of my work there was doing outreach. So this was in the era before podcasts. So we did sort of a proto-podcast, also known as a radio show, on science and society. And I learned a lot about public health through that experience. And that kind of got me interested in thinking about public health. After that, I went to Ladakh, which is in Northeast India, with a program called Himalayan Health Exchange. And we did basic public health work, and I was living and staying in households that burned a lot of yak dung. There's a lot of wood use and a lot of smoke. And that got me starting to think about how that might affect health. Didn't really have the vocabulary, understanding, knowledge, any of that to put it together, but did sort of spark a fire in my head. And I have to admit that I went to Ladakh because I wanted to go to the Himalayas, and doing some public health camp work was an added bonus. I came back and applied to the Rollins School of Public Health at Emory University, got a Master's of Public Health in Global Environmental Health, and did my field work in a slum community in Mumbai called Dharavi, and that was funded by the IDRC. And there, it was sort of an occupational air pollution assessment. The folks use kilns to fire their pots, and the pots are the kilns are in the middle of the slum, and they use whatever they could find as a fuel. So that could be plastic, gloves, trash, leftover food, so it produced a lot of smoke. Of course, in that context, in a slum community, air pollution's one of a number of problems. It's not the only thing they're worried about, but it was probably the hardest field work I've ever done. I don't know if it's because it was the first field work I'd ever done or if it was actually harder than the rest. I finished up my degree and went to Nepal for a year as a Fulbright scholar, where I did an evaluation of a clean cook stove program run by the Nepali government. They installed around 250, 300,000 of these stoves, had never done any evaluation, so we did a bit of that. We measured particulate matter and carbon monoxide in homes before and after the installation of these stoves. They didn't do a whole lot. They were very simple, inexpensive stoves. They didn't reduce pollution levels all that much. While I was there, two significant life events happened. I met the person who became my wife and partner, and I met my PhD advisor. I'll leave it to you to decide which is more important. And I'm sorry for those of you who heard that joke yesterday. It's one of my favorites. And then so I met Kirk Smith, who became my PhD advisor, went to Berkeley, where I did my PhD between 2010 and 2016, stayed on as a postdoc and became a lecturer in the department and got principal investigator status late last year, early this year. So we're going to talk today about the 4 fuels that are commonly burned around the world: wood, coal, charcoal, grass, and dung. Just a tip that if you search on Amazon for cow dung, you will find this, and then you will find it following you as you search for other things. It's not great. So 3 billion people use these types of fuel for cooking. The proportion of people using that fuel is decreasing, but the absolute number has remained relatively constant. It is starting to come down, but it's relatively constant. So there's a lot of solid fuel use around the world. And this is the distribution of solid fuel use globally. This is taken from a report that some folks here worked on. And it shows you, kind of not surprisingly, that the places where these fuels are used are also typically poor places. This is what it looks like. This is in India. So you've got, let's use this thing, maybe. Yeah, so you've got some dung and some wood, and this is a woman making chapati in Haryana, North India. This is an intervention stove in Guatemala, so the combustion is enclosed, still uses wood, and then there's a chimney in the back here. And this is what's called a 3-stone fire, 3 stones holding a pot, and then some wood, and this is in Kantampo in Ghana. So just to give you a flavor of what this looks like in the field. So you'll have cooking indoors and outdoors, and the exposures are fairly high. And here, the unfortunate side effect of taking this photo is that there were a bunch of kids standing by a fair amount of smoke, which of course we would prefer didn't happen. And of course, smoke that starts inside has to go somewhere, and a lot of it goes outside. There's been work done by groups in India and by Mike Brower's group here showing that 20 to 25% of ambient air pollution in India arises from household sources. So if we want to clean up ambient environments in your cities, you're going to also have to think about cleaning up household air pollution in these types of contexts. The other thing that stands out and that occurred to the field fairly late is that if let's say this house decides to stop using solid fuels and they switch over to a clean fuel, they're still surrounded by all of the other households that are using dirty biomass fuels. And so that means from an intervention standpoint, we need to move away from thinking about household-to-household interventions to thinking about community-level interventions, at least in the context where you have fairly dense villages where there's a lot of solid fuel use. So all that solid fuel use results in between 3 and 4 million deaths yearly from the exposure to PM 2.5. And to put that in context, the top 3 here are from the comparative risk assessment. So these are modifiable risk factors: ambient air pollution, household air pollution, water sanitation, and hygiene. The bottom 3 are diseases that public health folks often think about: tuberculosis, HIV, AIDS, and malaria. And you can see where household air pollution and ambient air pollution kind of fall in the mix. It's a big burden. These numbers are uncertain, but the point is that they're large, and it's a public health problem that we think warrants attention. So there's a lot of stuff released when you burn wood simply. Any of you who've been around a campfire know there's some things that smell great, there's other things that make you cry, and thinking about putting that in a home, it's not great. This is an incomplete list of the products of incomplete combustion: small particles, hydrocarbons, oxygenated organics, lots of nasty stuff. leads us to call a cook stove in a home a toxic waste factory that you sort of willingly and necessarily fire up twice a day. It's not, again, it's not a great situation, and so you want to think about ways we can transition these communities to cleaner cooking. We focus on PM 2.5. It's a commonly measured pollutant associated with adverse health effects. To put that in context, this weird shaped cylinder is supposed to be a human hair. The blue dots are PM 10, and then within those are PM 2.5. So it's fairly small, 2.5 microns or less, and it penetrates fairly deeply in the lungs, and it's associated with a number of health outcomes, including the 5 listed here, which are quantified as part of the global burden of disease. Those are acute lower respiratory infection, mainly in children, chronic obstructive pulmonary disease, ischemic heart disease, lung cancer, and stroke. So on the x-axis, we have PM exposure. On the y-axis, we have relative risk. And the striking feature of these curves is that they're not linear at all. And so if we want to move populations in solid fuel using households from like 500 and have a health impact, it means we have to really get down to the clean section down here. So, you know, halving their exposure, for instance, if we're looking at ALRI, brings the relative risk down from 3 to a little less than 3. So it has pretty big implications for the way we think about our interventions. Now, that assumes that these curves are correct, and there's new evidence suggesting that their shape might be a little different, but for the purposes of this talk, we're going to run with that assumption. So these are called integrated exposure response curves, and they're called that because they integrate information from ambient air pollution studies, secondhand smoke studies, household air pollution studies, and then way out there in the lawn somewhere, active tobacco smoking, anchoring the points here. So there are a lot of methodological issues that went into making these curves. One of the big things is the assumption of equitoxicity, that all of these pollutants are roughly of the same toxic equivalence with regards to dose. That assumption, of course, may not hold. Okay, so that's some background. I'm now going to talk about my research. I'm going to focus on 2 measurement campaigns I did and then 1 intervention campaign. So if we think about a village household, this is a little bit atypical for a village household in that it's 2 stories and most aren't 2 stories, but it's there to illustrate a point. There are a lot of things we can measure. We can use surveys and ask what type of fuels do people use and how often do they use them. We can measure microenvironmental air pollution, so we can take a monitor and stick it on a wall in a kitchen or a living room and figure out the concentrations in that room and ask people how much time they spend in the room. We can measure things like ventilation and the room attributes, so how big is the room, how many windows does it have. We can measure emissions, what's coming directly off the stove. And from a health standpoint, the thing we want to measure is personal exposure. So you take a monitor, you put it on a person, it follows them through space and time. That's obviously not easy to do. I wish they were this small and light. That'd be great. They're not. They're a little bit bigger. They make noise. The expectation is that you give it to someone and they wear it for 24 or 48 hours. That's not always the case. It's pretty funny to go back to a house, and as you're driving up, you see a house member run into the house and grab their vest and put it back on, and then tell you they were wearing it the whole time. Mike Brower's group, it's part of the Pure Air study, has been doing a lot of work using lighter, smaller, easier to deploy monitors. This has changed a lot in the last 5 years. There's better instrumentation now. So just to put that another way, these are all the parameters we can quantify that kind of modulate whether you use an open fire or solid fuels and your exposure. Ventilation, stove use, time activity, how much time you spend in the various microenvironments in your home, proximity, how close you get to the source, location, whether you're inside or outside your home, things like season, characteristics of the fuel, how wet it is, and then other sources in the home. So in a lot of these households, especially in North India where I do a lot of my work, there's not just one combustion device, there are 4 or 5. And it's hard to see here a little bit, but the things that are outlined in orange are systems that I've worked on to quantify these parameters in households. Blue are things I've collaborated with others on. I'm happy to talk about those. I'm not going to get into too much detail on those during this talk. So the first problem, tried to see how well our standard practice predicts PM 2.5 concentration. So we took a bunch of our monitors, which look like a smoke detector, and they are, in fact, a smoke detector that's been hacked. This device was created at Berkeley about 15 years ago. Not great for the developing world, but fine for these kind of contexts where the levels are very high. And we stuck them on the walls in Guatemalan kitchens for about 270 days. So the idea is if we take a random sample, a random single day from that huge data set, how well does it predict the long-term average? So we only deployed 8 of these, but we had a nice long longitudinal data set. And the first measure we looked at was the coefficient of variation. That's the standard deviation over the mean. It's a measurement of dispersion. And so if you increase your number of consecutive sampling days, what does that do to your dispersion? Not surprisingly, if you measure for more days, your dispersion goes down. And kind of the sweet spot, we think, is around 3 or 4 days. The marginal gains after that aren't that great. And if you were thinking about a big study where you're measuring in hundreds of homes, it's pretty impractical to figure out how you would measure for 28 days or even 14 days at a time. So you're trying to optimize the combination of the expense of the equipment and resources and field time with your interest in capturing variability and getting a precise measurement. Another way of looking at that, and these are fairly complicated, so rather than look at all four, we'll just zoom in on one, is decide on a tolerance from the mean, how close to the mean we want to be, and the probability of falling within that tolerance given these different sampling strategies. So the red line is what I talked about and what is our typical process of sticking a monitor on a wall for 24 hours. So if we want to be within 25% of the mean, and we do that, we stick a monitor on the wall, we have a 40% probability of being within 25% of the mean. So 75% of them are beyond that. It's not a great sample. It's probably not the best strategy. As we look at other strategies, like a random day by study week, so once per week, which is a lot more samples, or a random 48-hour period per season. In Guatemala, there are 3 seasons, so this is 6 total samples. We get closer to what we want. This kind of shows you that random practice, or the standard practice, doesn't satisfy us very much in terms of the precision of our estimate. So to summarize, short-term measures, perhaps not surprisingly, but there was no data to back it up, are unreliable estimates of average annual concentrations. So that's the first project. The second project is pretty related. It was another long-term application of sensors, this time stove use sensors, and I think I've got one in a pocket, maybe. I'll keep talking while I try to find it. So the idea here was that we were going to deploy an intervention, and we wanted to know if people used it and how often they used it. And we can ask them that, but they don't necessarily give us a good response. So we wanted to monitor it objectively. So we use these little things, which are called eye buttons. There's a picture of one on the slide as well. And they are data logging thermometers. And we deployed them on both the traditional stove and the intervention stove for a long time to see what was going on in the field. This was part of a project called the Newborn Stove Project, and the ambition was to find a stove that people will use that could be used to assess the impacts of a clean stove on birth weight. I'll talk a little more about why that didn't go forward in a second. So in India, around 1 million deaths per year from household air pollution. 2/3 of houses use biomass for cooking. We worked in a district called Palwal. It's south of Delhi a bit. So the star here is Delhi, and our field site's here. It's a field site run by our colleagues at the International Clinical Epidemiology Network. They follow 51 villages, 200,000 people. They do routine census and epidemiological surveillance. So they have a tremendous infrastructure set up for doing population health studies. In this site, 77% of households use biomass, and somewhat uniquely for India, 94%, uniquely is that they cook outdoors, 94% gather fuel. That's not too unique. And that's just a map of the area. And the red line here is a big road that's being constructed, as is this line. And so this is an area that, despite being fairly far from Delhi, is rapidly urbanizing and changing. It's changed a lot in the 10 years we've been working there. So this is what cooking looks like there. You saw a photo like this earlier. This is a traditional stove called a chula. And this is our intervention stove, the Philips forced draft biomass cook stove. At the time of our study, as we were planning this in 2009 and 2010, this was the cleanest biomass cook stove in the world, as tested in the lab. So when used properly with the right size fuel, with the right moisture content, it's very, very clean. It's almost as clean as gas. Of course, that's not necessarily what happens in the field, and I'll talk about that some more. So we found the stove, we tested it in the lab, and then we went to India and spent about 6 months testing it to see if people liked it and if they were willing to use it, and they were. And it's been tested elsewhere in India as well. So we weren't going in completely blind with an untested intervention. We, at the time, were fairly confident that this thing was going to work. And you can see the little stove use monitor on the stove. So the nice thing about a manufactured stove is you can put the sensor in the same place on all the stoves. And so you might be wondering, oops, got ahead of myself. So that's the size of the sensor. Again, they're relatively inexpensive. At the time of the study, they were about $12 each, 12 US. Now they're around 25 or 30. They've gone up in price. You deploy it on the stove, and then the field worker visits the house every couple of weeks and touches a sensor to the front of the device, and that downloads the data to a computer. So it requires fairly intrusive action by field workers into homes. And this is what the data coming off of them looks like. So not to give away the punchline, but this is pretty typical. At the top is the intervention stove, the Philips. At the bottom is a traditional stove. And you can see that the Philips is only being used on occasion. So when the temperature goes up, that's an indication of use. Pretty easy to tell when there's use on the Philips stove. Kind of easy to tell on the traditional stove. The traditional stoves heat up more slowly. They cool off more slowly. And these sensors can only get up to 85 degrees Celsius, which means they have to be placed really carefully. So you want to put them on the stove in a place where you can detect a temperature change, but where it's not going to get too hot and where it's not too affected by slow thermal decays. So this is fine. You and I can all look at this and we can guess what's usage and what's not, but we had something on the order of 25 million data points, 143,000 days worth of stove data. So we had to figure out a way to process this data. I'm not going to go too much into the intricacies of that. We came up with some clever algorithms that churned through it for us and then validated them by hand, which is one of the thrills of being a grad student, printed out or looked on a screen at 1,000 graphs like this and assessed the performance of the algorithm. I don't advise doing that. It's not fun. And I'll talk about some tools we've built to greatly facilitate this analysis. So for the study, we recruited 200 pregnant women who were all had open fires at the start. We stuck a usage monitor on their traditional stove. We intervened with the Philips. We stuck a usage monitor on the Philips when we deployed it to them. So we had this nice period before the intervention where we could track their traditional patterns before we went into their house and gave them this thing and asked them to cook on it and really sort of disrupted their day-to-day patterns. And then we followed them through delivery. And as I mentioned, it was quite a bit of data. At the time, it was the largest stove use monitoring data set in existence. There's been bigger ones. In fact, we've generated some bigger ones since. And we took all that data and we summarized it down to a couple graphs, which I'll show you, which is both kind of exciting and disheartening at the same time. So this is prior to the intervention. We monitored on average for about a month. And we saw about 200 minutes of stove use per day with the traditional stove prior to the intervention. After the intervention, there was exclusive, what we call in our field, stacking, so use of both the traditional and the intervention stove. In other fields, you would think about this as compliance or mixed use. And you can see that while the traditional stove use did go down, it started to go back up towards the end of the study, and the Philips really didn't do much. It kind of leveled off at very low use. So when asking households what was going on, well, one problem was the stove broke a lot. The second problem was about 6 weeks into our study, Philips stopped manufacturing the stoves in India, and so we had the last batch of parts and pieces and repair time, which was challenging. And third was it wasn't really suitable. It was better as an appliance than a replacement. So that gets into more of the behavioral issues. Prior to this study, there had been only one or two others that had done any sort of long-term tracking of an intervention. So one of the things we wanted to take away from this study was that it's important to track these behaviors over time. If you just look at the first few days, you might be excited, yeah, people are using it. Also that you want to keep track of the traditional stove, because just because you give someone something new doesn't mean they're going to use it. And again, this isn't a novel insight. This is pretty common for public health, for condoms and bed nets and medicines. You have to kind of keep on people to make sure their behaviors are changing over time. We did some mixed modeling, mainly to try to understand whether the variability was between homes or within homes. So we'll focus a little bit here on the interclass correlation coefficient, the ICC, which is the proportion of the variability that's between homes. And that's very low, meaning that a lot of the variability is coming from within homes. Stuck a bunch of other predictors into these models to see if they helped predict our usage patterns that we detected. They didn't, which is a little surprising. I'll talk a little bit more about that at the end, if time permits. And the last thing, and this realization came to me right before we submitted the paper, which is often when realizations come, is that we weren't really comparing apples to apples. A traditional stove is really inefficient. The heat transfer efficiency between a unit of fuel and the pot, or the useful cooking energy, is pretty low. So we tried to put the two stoves on an equal footing using a metric called utilized cooking energy. And so that takes into account the cooking power of the stove times the minutes of use to get a proxy of energy use. We didn't measure that in the field, so we used laboratory-based measurements. Tells a very similar story with one interesting addition in that the total energy use at the start was a little bit higher. So people were using both stoves, sort of a rebound effect, the kind of thing you see if you give someone more efficient appliances, they use them more. It doesn't really displace things. So that was a pretty interesting secondary finding from the paper. So this study's been published. There have been 3 papers so far, and a 4th looking at predictors of cook stove use. So out of those 200 households, there were 20 that use the stove all the time, almost exclusively, and we're trying to figure out what's different about those, and that's hopefully coming soon. So the takeaway is pay attention to both your traditional stove and your intervention, track things. You don't necessarily need to track continuously over time, but you do want to track over time. And then the second big takeaway was we had to figure out a way to make this data pipeline easier to use, manage, and analyze. So it doesn't sound that complicated. Field worker goes to a house, downloads data onto a laptop, but we need to make sure they name the files properly, that they upload the files, that the files are complete, that the sensors are working, and then multiply that by 400 stoves and 200 households spread out over a fairly large distance. And it means that anything we can do to make the sensor placement and download easier is useful. So I've been working with a company called Geoscene to create a slightly better sensor. It's a little bit more expensive, but it's reusable. Once these burn up, they have to come back to the US to get recycled. It's not great. So these run on AAA batteries. They can go up to 1200 degrees Celsius. You don't have to go in the home to download data. Beams it over to your phone via Bluetooth. And then it goes up to the cloud to a platform to analyze the data and automates a lot of the data analysis. So I'm happy to talk more about those with folks that are interested towards the end. Okay, the last project I want to talk about kind of brings these 2 spheres together. And it's, again, a pregnancy cohort. So coming back to that idea that I presented in that past project, to try to see if we could enhance clean fuel use during pregnancy. So right now in India, there's a big emphasis on clean liquefied petroleum gas, or LPG. You can think of your propane or butane canisters that you use for barbecuing in the West. And there have been these 3 programs that are trying to increase access to this clean fuel for the rural poor. We're going to talk mainly about this bottom one, PMUY, or the Ujjwala scheme or program. The goal is to provide 80 million households with clean fuel by 2018. By 2019. As of 2018, it was around 50 million households. This is a tremendous undertaking. It's really hard to describe it. There's kind of more happening in a month in India as far as interventions for household energy go than have happened anywhere else in the world, probably in some. So they estimate that they're signing up 3 million households a month for this clean cooking fuel. Now, just because someone signs up for it and gets the stove and the cylinder in their home doesn't mean they're going to use it. And so the big challenge, we think, as public health people and from a policy standpoint, is getting people to transition over to clean fuel. And this project is focusing on transitioning particularly vulnerable folks to clean fuels. Those are the rural poor, particularly those that are pregnant or are recently married. So in this study, we targeted critical life course events. Pregnancy, in India, we can typically capture pregnancies between 12 and 16 weeks. So through the first trimester, start of the second trimester. And marriage was a new idea. The concept there is that a lot of, in rural India, especially in the state we're working in, Maharashtra, where we are, it was estimated that about 60% of newlyweds get married within the first year. So if we can enroll them at marriage and get them to use this clean fuel throughout that first year of marriage into their pregnancy, we can protect the entire pregnancy. And it's thought that that first trimester is a critical window for exposure. So it was a way to try to expand the proportion of pregnancy that we can protect. Now, due to time constraints, I'm not going to talk too much about the marriage arm. If anyone has questions about it, I can answer. I'll say that it's working, it seems. Not as many people are getting pregnant as we expected in that 50 household arm, but those that are pregnant have their entire pregnancies covered with clean fuel with a fair level of usage. In the pregnancy wing of the study, we had 3 interventions. We had a core intervention where we gave people a stove, 2 cylinders of gas. You might ask, why 2 cylinders? When you run out of a cylinder of gas in a rural area, it can take anywhere between 7 and 14 days to get your cylinder refilled. So by providing 2 cylinders, you avoid that break in coverage, so people have continuous fuel supplies. A table, some tubing, lightering, and then some health and safety messaging, which, if there's time at the end, I'll show you. We spent a lot of time in the community figuring out what health messages might stick, and did a bit of testing before and after the study to see if any of the messages did stick, and some of them did. We had a conditional cash transfer arm. CCTs, as they're known in India, around the world, are fairly common in India. It's payment for a particular behavior. So in this case, if you used your LPG stove, we gave you 2 rupees. It's about half the cost of the fuel. didn't want to give them enough money where there was an incentive to just crank the fuel and leave it on all day. So it's a little bit less than the cost of fuel. And we created a new sensor for measuring that just reports the number of meals cooked with a stove. And then we had an arm where we just provided free fuel, 1 cylinder per month. The cylinders are 14.2 kilograms. And it's estimated that for a standard family size, that'll last between 4 and 6 weeks. So those were the 3 arms. This is what the intervention looked like. It's a little dark. Where's my pointer thing? So the cylinder's right here. Here's the table I was mentioning, and then here's a 2-burner stove. Oh, thank you. That's so much better. We asked households voluntarily if they would either fill their chula with rocks, fill it with mud, or disable it and move it outside. About 80% of the households agreed to do this, but because if you put rocks in that thing, you can easily take them out, and there's evidence of use of this one. The rock is pretty burnt, and there's a lot of ash. We left some data logging thermometers, similar to the ones I mentioned previously, attached to the stove. There were similar monitors attached to both burners on the LPG stove. So we were able to track whether people were using LPG and how much they were refilling it. We measured PM2.5 concentrations and exposures before and after the intervention. And then largely this was evaluating feasibility of a big LPG intervention in rural India, where there's sometimes a long distance to travel for the distributor, the person who supplies the fuel, to give the refills to the households. So I'm going to talk about the air pollution findings and the stove usage findings. So a couple things that stand out here. The kitchen concentrations, which are the baseline measurements, and the core, the CCT, and the free fuel arms are very high, on average around 500 micrograms per meter cubed for a 24-hour average. Again, this is in the kitchen. And post-intervention, they go way down, an average decrease of around 82%. So the levels are coming down. People seem to be using the stove, and they're all significant differences between the pre- and post-intervention levels. And just to visually depict that, these are the x-axis is log transformed here. There's some separation, and in these households where post-intervention there appears to be fairly high concentrations, it turns out they were still using their traditional stove. So it's useful, again, to have that stove use data to be able to disentangle some of the stuff. We haven't worked up the exposure data yet, so I'm not able to yet talk about it. We expect it to show fairly similar patterns. So this is the stove use by study arm. These are the days before pregnancy. So day 0 here is the day of delivery. We thought that the best way to standardize this data was by data delivery. And the size of the dot is the number of households that were monitored. And the pink dots, or the red dots, are exclusive LPG use, so no chula use. And then the bluish dots, the gray-blue dots, are any chula use. So that's either exclusively using the traditional stove or using a combination of both stoves. And the somewhat disappointing results here are from the conditional cash transfer arm, where there's pretty consistent use of both stoves throughout the study. That conditional cash transfer didn't work. There are a number of reasons it didn't work. We had a lot of problems with the implementation. Originally, our field partners didn't want to give cash to households. They wanted the cash to be directly deposited in the bank accounts. So we set all that up. We made sure all the households had bank accounts. We got their bank account numbers. We got permission to deposit into their account numbers. And then we sent the first set of deposits over to the accounts people, and they were all like between 50 and 100 rupees, so between $1 and $1.25 US. And the bank people were like, we're not doing that. It's too small. So that meant that in reality, this thing wasn't properly implemented, where we were actually paying people promptly until pretty late in the study. So we think it was more a implementation failure than anything else. We don't know. We're going to try it again, hopefully. Now the good news, thankfully there's some good news for once, is that in the free fuel arm there was almost immediate and complete separation. So there was a lot of use of the LPG stove, very little use of the chula. And it stayed fairly constant throughout the intervention. There was still occasional use of the chula. We're digging into why we think that was happening and how frequent it was, but for the most part we had good separation. Now that may not be surprising to you. You're providing free fuel, of course they're going to use it. I was still pretty surprised. A lot of people say that it's not really the fuel. If you talk to households, it's not the fuel. They don't like the way the food tastes. They don't like cooking with LPG. But it seems to be that if you provide the fuel for free, those concerns go away. We've provided biomass stoves in the past for free, and I've never seen anything quite like that. So again, this is pretty reassuring. And to put some numbers behind that, if you look at the percent of days with LPG only in the first yellow box here, in the free fuel arm, or FF, it was 90% of days were with LPG only. So again, a good sign that people are using that clean fuel. We did all the sort of standard statistical tests you'll do to make sure those distributions are actually significantly separate and different. The core arm and the conditional cash transfer arm were not, and the free fuel arm was distinct from both of them. So you might think, well, that's crazy. You're not going to provide free fuel during pregnancy to all rural, poor, pregnant Indian women. I'm going to argue with that and say I don't think it's that crazy. There are national programs that already provide cash transfers. So again, I mentioned this previously. If pregnant families attend all of their antenatal care visits and deliver an accredited facility, they get anywhere between 50 and 300 US dollars, depending on the state. The cost of fuel to cover a pregnancy identified in the second trimester is well within those benefits. And the potential public health relevance here is that the meta-analyses that look at the relationship between clean fuel use versus biomass use and birth weight indicate a 90-gram difference. So households that use clean fuels have babies that are 90 grams heavier. At an individual level, that's not all that much, but at the population level, you can think about shifting a whole population over. So we're still working on the best ways to present this data. We've got meetings with the Ministry of Health and the Ministry of Petroleum and Natural Gas later this winter. And we hope to scale up the study. This was small, 50 households per arm, 200 in total. Definitely not enough to really make a push for a policy, but enough to say that we think this might work, and we've learned enough to do it a little bit better in a bigger study. And just as an aside, I mentioned this to some of you, but if you had told me 10 years ago I'd be working with the Ministry of Petroleum and Natural Gas, I probably would have run out of the room screaming. But they've been great partners, and they seem to have internalized the potential health benefits of this at scale and seem committed to getting households using clean fuels in rural areas. We'll see if that commitment holds up after the elections, which are coming soon. Okay, so I'm going to wrap up by talking about my ongoing and future work. So a few years ago, we got a large grant from the US EPA to study how all these household sources I've been talking about impact ambient air quality. And we're doing that by making better emissions inventories. So doing a lot of emissions measurements in homes during real cooking events in North India with colleagues from across the US and in India. The folks doing the emissions measurements are at UC Irvine, Caltech, and they did intense 3 winters of measurement where they were trying to characterize the volatile and semi-volatile organics, things that are not easy to characterize in these contexts. All the samples had to get shipped back to the US. It was fairly tedious. So with that, we get better, improved emissions inventories, and we can run chemical transport models to estimate the contribution to secondary aerosol over North India. The results from that just got to my inbox a couple days ago while I was here, so I haven't had a real chance to dig into them, but I think it's going to be pretty interesting. We did some other things during that study. We set up rural ambient air pollution monitors in small villages in India, kind of in the middle of nowhere. There's not a lot of rural air pollution measurement in India. Most of it's focused in urban areas. Turns out the levels are really high, and 60% of the Indian population still lives in what are deemed rural areas in India. Indicates that there's probably a need to set up monitoring networks outside of the population centers. And then the last thing, which was really fun, and if there's time at the end, we got a small DJI drone, put a particle monitor on it, and we wanted to see if we could quantify the inversion height in these villages in the winter. So after many, many months of talking to villagers and convincing them we weren't taking photographs or spying on them, we flew drones kind of straight up and down through the sort of blanket of pollution. And the inversion height was higher than anticipated. We were expecting it to be around 400 meters. It was closer to 600 or 700 meters, which is above the of flying a drone in India. So trying to figure out how we're going to present that data, if we're going to present that data. And the second study that's ongoing is a little different. It's focused on heating in Mongolia, which is has the dirtiest capital city in the world, but only in the winter. In the summer, it's beautiful and very clean. In the winter, they're in a valley, ground level inversions, lots of coal use. There's some pretty iconic photos of the smokestacks from the power plants sticking through the inversion layer and just a blanket of smog. And that's all from household coal heating. So with some colleagues in China, we identified dual compressor heat pumps that use electricity that could be rolled out in Ulaanbaatar as an intervention. We piloted a very small number of those, 7 last winter, to see if they would supply sufficient heat to households, if households would use them, and if they would break in the extreme sort of circumstances of UB in the winter, Ulaanbaatar. And they didn't break. Households used them insanely. They turned the temperature up to about 30 degrees Celsius, so they weren't paying for the electricity during that little study. In the future, they will be paying. So we think that'll regulate a bit. We have some grants in to do a 500 device rollout for the winter of 2019 or 2020. 500 is a drop in the hat. The scale in UB is on the order of 20 to 40,000 that you would need. But again, we want to see what's going to happen with the grid, with indoor pollution concentrations, and if people will actually use them. That work is being supported by the Mongolian government, a loan from the Asian Development Bank, and a South-South climate change cooperative agreement with China. A few more proposals. We created a cheeky software tool called Sumserizer. These little things are called sums, and so the Sumserizer summarizes sums data. And the way it works is you upload all your data to the cloud, and then you go through and you hand label. So if you upload, let's say, 1 million days of data, you hand label around 1,000 days of data. You say, all right, I think this is cooking. Then you submit it to a machine learner, a supervised learner that classifies all the rest of your data. Takes between 2 hours and a day, depending on how busy the server is. Automates that data analysis. This tool is great for analyzing stove use data, but it's usable for any kind of either frequent or infrequent event that you want to detect. And so this was a collaboration with folks in engineering at Berkeley, and we just got some money to kind of fix it. It's been broken for a few months. We did it as grad students in our spare time. Do grad students have spare time? I guess they do, to do this kind of stuff. And just recently we're funded. So it was funded by the Implementation Science Network, which is interested in creating open source tools to do this kind of stuff. So very excited about that. Then we have a few projects with the Indian Council for Medical Research. I talked about this, providing 2 cylinders to households. Makes a big difference in rural areas. Continuous fuel supply. So if you live in an urban area, if you live in Delhi, for instance, or Mumbai in India, everyone, if you go to a house, they all have 2 cylinders. Because if they run out of gas on Friday night, they need to be able to cook over the weekend, and it might take 48 hours to get that refill. So we were thinking, why not try to do that in a rural area? So we're doing that, and then the second is a more qualitative study looking at drivers and barriers to LPG use. And that's being led by our colleagues at KEM Hospital. And then finally, we want to do, because of all this big change in India that's occurring, we want to try to do a blood pressure study to see if we can see changes in blood pressure before and after this LPG intervention. And that's in development. And one of my totally tangential, but just to show you that I'm not completely stuck in thinking about household air pollution, is I'm pretty interested in heat stress, which we know is a growing problem globally. It is well characterized by models around the world, but there's a pretty substantial lack of measurement on the ground in rural areas. And so it'd be interesting, I think, to take some of my experiences deploying low-cost sensor networks and deploying them to measure wet bulb globe temperature, which is a good indicator of heat stress around the world. And these are the types of questions I think I could answer. I'm not going to go into too much detail there. So I've got a bunch of research partners. Regardless of whether I end up here long term, hopefully I do, I'm happy to try to connect folks who have interest in working in these places or on these issues with collaborators around the world. And I've been fortunate that when I got to Berkeley, a lot of doors got opened for me, and I'm happy to pay that forward. And I've done a fair amount of teaching at Berkeley and globally. So at Berkeley, I was a lead graduate student instructor for a big 120 to 180 person breath course, and then I started a new global air quality and health class last year. Those are some courses I could teach. One last thing to wrap up with is I've run household air pollution trainings around the world for ministries of health, for EPA equivalents. And so the idea here is to kind of help countries build up their own capacity to do these measurements. I think it's really important that as a person working in environmental health globally, we try to build capacity in areas and aren't just flitting over often to do the measurements ourselves. And I was going to say I've been lucky enough to contribute some chapters to textbooks. It's quite a task, so I've contributed some chapters to textbooks. It's a good way to think about communicating some of these issues in a clear fashion, which I hopefully have done today. I want to thank my advisor and mentors at Berkeley, and our program manager, Maria Teresa Hernandez, and especially, who's been really helpful and thoughtful throughout the years. My comrades in the program, and then global colleagues, and of course our sort of swath of funders over the years, and all of you in the department for inviting me over. Thanks so much. Leave that on.
Thank you very much.
Thanks.
Covered a lot of ground in a short period of time. Thank you. We're going to open it up for questions. We do have time for questions, both in the room here as well as I'll facilitate some questions from online. I'm going to walk around with the microphone so that our online audience gets to hear these questions as well. Michael.
Yeah, thank you for that talk. And I know, yeah, listening to that, obviously you outlined quite well the issues in public health of trying to modify behaviors and yeah, some of the difficulties with that in public health initiatives. So I know particularly with your third project that you talked about, you showed that there were some good indicators on sort of how to actually modify behavior. And I was just wondering, for either that project or other projects, are there A, any plans for scale up in those, and B, how are you really implementing it at the community level so there's actually that potential for behavior change?
Yeah, great question. So yeah, we created these flip books, and this is going to be dangerous. See if I can find them. Yeah, so these are the English versions, and they're a little out of order. So this was the first slide there. Clean LPG, Clean House, Clean India, obviously translated into Marathi. And let's see how many more are in there. Yeah, I guess in this community, there's a lot of water heating. This was something we didn't anticipate and found later. It gets hot in Maharashtra, but doesn't matter if there's water, heating of water every day for bathing. And so rather than do that inside, we're going to move it outside. Don't expect people to spend their money on LPG doing that. But yeah, so we're doing this kind of thing. And the way it worked is our field workers went to the communities and organized community meetings of households, both those in our study and those outside of the study, and talked through this either with a projector or with a fairly large flip book. We have sent this to the Ministry of Petroleum and Natural Gas. You know, again, we've got one community where it worked. This thing is really flopping around. So we don't know if it'll work all over the country, but we're hoping they'll take it up. They have a big communication program called LPG Panchayat, where they're supposedly going to roll out in 100,000 villages some behavior change around these issues. So trying to influence that. Don't know if we'll succeed. Thanks.
Thanks very much for that presentation. It was wonderful. A couple of questions. The first one was just a follow-up clarification around the free fuel study. I just wondered, because you compared it to the chula use, what was the fuel source for the chulas? How easy was it for them to access that? And
yeah, sorry.
In other situations, would people?
I should have mentioned that. It's mainly wood in this area. There's a little bit of dung use, but it's very small.
And so it's relatively easy for them to find, or was
it depends on the household in the village. So some of the households, yeah, it's very close, and others it's not. And we have some data on that from the 200 households we worked in, and it's a mix of whether they collect sort of regularly, once, twice, 3 times a week, or go once a month and collect a whole bunch and store it. And I haven't looked at the associations yet, but my guess is that the poorer households are going more often, and the richer households that have some space are storing it. For post-study, which I didn't show the data, that free fuel arm is still showing pretty high levels of usage, so they're actually paying for the fuel now. We don't know how long it's going to last. We're going to keep monitoring until our money runs out.
Thanks. One more question, if I can. The slide that you used of the human hair and the blue, and I use the same slide. I think it's the best slide ever for trying to explain that to non-experts. But I use it in my occupational health studies. So it just made me think if you'd thought about co-exposures to non-combustible sources like occupational sources, dusts, and so forth.
Yeah, we think we are worried about the dust thing, not so much in this context, but in some other places we're working, Rwanda in particular, where we're seeing very high levels when there is no clear signal from cooking, and we think it's coming from occupational sources, largely from agricultural dust. I would say that outside of some time activity diaries and stuff, we haven't done a great job of teasing that out. And as communities move to cleaner fuels, it's going to be really important that we figure out what the sources are. for a long time, the assumption has been that the strongest source in these villages is the stove. That is starting to break down a bit. That's a great question.
Thank you very much. I have a question regarding the seasonal variation. Have you seen much seasonal variation in their usage of LPG and chula?
Yeah, it's a good question. There is definitely seasonal heating in Maharashtra where we are. It's near the Ghats. Gets not cold, but cold, and it's very rainy. So there's seasonal heating. We probably missed some of that because we weren't funded to instrument every stove. So we instrumented the primary stove. We do have some observational data on heating. We haven't noticed any change in the LPG use by month. I did look at that. We'll check it again, of course, but yeah, I'm not sure about that component.
Manal, are there some online questions? Not yet. Okay. I'll jump in. I mean, it's clear your passion lies with the monitoring and the devices. I'm just interested in some of your thoughts of the application of that more locally. Great examples globally, and thinking about the application of that to research issues more locally.
Sure. So I think I was talking with Sarah earlier today about heating with wood stoves throughout, and I think if we wanted to get a good idea of how frequently and how intense that's happening, we might be able to use some of these stove use monitors. Again, that's an in-depth proposition because you're going to go into homes and instrument things, but you would get the same kind of information about use patterns. More broadly, there is still wood use for cooking and space heating among First Nations or indigenous communities, and it is an area of interest. I've done a little bit of work on those fronts in Northern California where there's still communities that rely on wood primarily for heating, though also a little bit for cooking. And there, I think, rather than a whole bunch of measurements, it's a lot of awareness raising and then bringing up issues with the appropriate authorities to try to get change made. It was, some of you heard this story, but we were asked to go work with this tribe called the Yurok in Northern California. There's a community that's completely unelectrified, so for the school they had a diesel generator, which was very, very close to the school, with the exhaust pipe pointing in the direction of the front door. So they wanted us to come up and do measurements. We got there and decided we didn't really need to do measurements. It was pretty obvious that this was a bad idea. But it took a year and a half of, I will not claim any prominence, but the folks I went with, John Bombs, who sits on the California Air Resources Board, and Kirk Smith, who's an expert in this stuff, took them a year and a half to get anything done. It's a slow process. There's not a lot of political will there. So, I'd be interested in engaging on that front to the extent possible.
Thanks, great slides and presentation. So I was wondering your thoughts on the makeup of the home, because like ventilation and indoor, the structure of the home obviously plays a role in how much exposure to indoor smoke is, and at what point do you start looking at interventions on looking at ventilation changes or windows or that kind of thing?
Yeah, it's a great question. So we've done some work on that, created a sensor system to measure ventilation in households, kind of objectively, using a tracer gas method, just releasing a big bunch of CO2 into the home and measuring it and seeing how it decays and quantifying ventilation rates. Turns out that these households are fairly well ventilated. They're not super tight. They are tight, but they're not super tight. There's a lot of leakiness around the roofs and the doors and the windows. There has been some work on mechanical ventilation in these settings, or just opening windows and doors. In areas where the households are fairly far apart, that's a pretty good strategy. It's still not going to bring the levels way down. In areas where there's density, though, it's not all that helpful because you just have sort of infiltration and exfiltration from houses next to each other. Everyone's breathing the same community level air shed. But yeah, there's been some work on that. I haven't done too much of it other than trying to measure it.
Last question to Sarah. Okay, getting my steps in. It's good.
So you were talking about the fact that it's not actually crazy to go supply women who are pregnant with natural gas or LPG. That's looking at one single health outcome, which is the health of an infant. I assume that once the women have the infant, you go back to the status quo or some such thing. So why is there consideration of simply supplying the entire population with LPG? Wouldn't that be cost effective in the long run when you add up these health effects?
Absolutely. There are a couple things I think are challenging there. I think we have a ways to go before we can make the case that that is sort of the government route to go. Subsidies in India are a tricky business, so they're already trying to whittle away at the subsidized fuel level. So everybody in India right now gets subsidized fuel, and it's not clear how that's going to go long term, whether the subsidies will remain or not. I agree that targeting just pregnancy and then leaving and there being no fuel isn't great. We think, and we have some evidence that I'm still working on the analysis for, that after we leave, there's still a fair amount of LPG use that kind of, at least for the mothers, they see the value in getting the fuel refilled and are willing to pay for it. And that's pretty promising. It's not at the same level, obviously, but it would decrease at least some of the exposure. So that's kind of where our thinking is now. But I broadly agree. I mean, it would be great if they could provide subsidized fuel or free fuel more broadly.
I am going to bring it to a close there. Before we thank our presenter, I do want to encourage everyone to please go to the link and provide an evaluation of this seminar. It's your chance. If you're a student, it's your chance to have some input on somebody who may be teaching you in the future. For colleagues in the room, it's a chance to provide some feedback on somebody you may be working with in the future. So the search committee would welcome your feedback via that form. And on that note, I'm going to ask you to join me in thanking Dr. Pillarisetti for sharing his research with us this afternoon. Thanks very much.